नेशनल कोऑर्डिनेशन तक सही है, उसके बाद सी गलत है। टाइम अप। Okay, your second question. बस ये को फिल करने का। ओके, वेरी गुड, वेरी गुड। आगे। Okay, so your two questions. Please use the mics while answering. Please, please do. See, तो बस yeah. Yes, very good. Indian Council of Medical Research. So you note on your points there also. विनोद जी, इनका भी करेक्ट था एक, और इनका एक करेक्ट है। इनका दो क्वेश्चंस में एक करेक्ट है, राइट? और इनका दो क्वेश्चंस में फर्स्ट वाला तो करेक्ट है अभी। योर सेकंड क्वेश्चन, राइट? Time up. Okay, let this question go to the audience. क्या? Absolutely. Okay, so the first round is completed, right? So we will be starting the second round. बस correct, correct. एक Okay, please read the instructions carefully. Round 2, they are similar to the round 1, but anyhow, please go through the instructions. Here only one question, image based question will be there in this round. Okay, only one question. Let's start. Okay, the first question for team A. Think, please think, you have 1 minute. For every question, almost try to give clues also. Time हो गया? Yeah, atropine. Yeah. Then question for team B.
Digitalis.
Very good, very good. Correct answer. आप मार्क्स डाल दें, ठीक है? Okay, so question for team C. Use the mic.
Morphine.
Very good. Question for team D, right? Please, please. When someone is answering, please. No. Time up. Okay, this will go to the audience. Audience है, please. उनको भी सर्टिफिकेट देंगे. Anyone from the audience? Okay. Okay, so this will conclude the round 2, right? So next we are moving to round 3, right? So we will just announce the scores up to now. Which team got how much score? We will just कितना कौन सा टीम को कितना मार्क्स है एक बार. So team A 10 marks till now out of 2 rounds. Team B 10, right? Team C 20, very good, and team D 10. Right? So we have 2 more rounds here. Please go through the instructions of round 3. Clear? Right? let's start. For team A, your first question. Very good. 10 marks. Your second question. एक क्वेश्चन का एक मिनट वो पुराना मिनट का टाइम अप. ठीक है. ओके, सो टीम बी, राइट, युवर 2 क्वेश्चंस. फर्स्ट क्वेश्चन.
Sir, ipratropium.
Very good. 10 marks for the first question.
Sir, atorvastatin.
वो हाथ देख के बताओ ना.
Atorvastatin, sir.
ऐसा आता है क्या? वो स्पेलिंग लिख के देख लो एक बार, उसमें कुछ मिसिंग है क्या? Time up. Time up. Okay, so for team C, you have 2 questions. Use mic.
Ibuprofen.
Yeah, correct. Time up. How to tell me properly, right? You have to. I am telling you and once again कि भाई use mic use करो और अच्छा बताओ. फिर बाद में आप change करते रहे. You should be confident to say this is the. आप तो उसको भी फिर change कर रहे हैं. फेबुस्टेट कहाँ है? फेबुक्सोस्टेट कहाँ है? ठीक है. टीम डी. Time up. Okay, your second question. Use the mic and say.
Domperidone.
Very good. Correct answer. So with this we are completing the round 3, right? So next is the last round, rapid fire round. I will show you the instructions. इसमें चेंज करने की जरूरत नहीं है, कुछ भी चेंज करने की जरूरत नहीं है। मैं उससे मेरे पास पेपर है, मैं इससे पूछ लेता हूँ, ठीक है? बस एक मिनट। तो एक बार मैं okay, so let's see the marks here. The team A 20, right? Team B 20, team C 30, and team D 20. Read the instructions. Let's start. There will be no question displayed here. I am going to ask you. No question will be displayed, right? So your time starts. If you know the answer, if you are telling true or false, or you can say pass, I will go to the next question. If you just think about that particular question, then your time will be passing on. That's it. Okay. Let's start. Okay. So your first question: fenofibrate is a hypolipidemic agent. True or false? Fenofibrate is a hypolipidemic agent. You have to be fast. If you don't know, just pass. Next question I will go. There are 5 questions here. Pass? Okay. It is true. Okay. So you will not get any marks here. But the second question, pralidoxime is used in the management of heparin overdose. Pralidoxime is used in the management of heparin overdose. Time is up. Correct. Metoclopramide is a dopamine antagonist. Is a dopamine antagonist. You have to be fast, otherwise your time will be passed off. Pass? Answer is true. Risperidone is an atypical antipsychotic. Risperidone is an atypical antipsychotic. True. An important adverse effect of loratadine is sedation. An important adverse effect of loratadine is sedation. एक टीम के लिए 1 मिनट है, 5 के लिए 1 मिनट है. ठीक है. Okay, be fast. Your time is already up, but I am giving time. Correct. Okay, so 2 correct answers. वहां पर मार्क्स डालने की जरूरत नहीं है, मैं डालता हूं, बस आप टाइमिंग चेक कर लीजिए बस. ओके, सो फॉर टीम बी यूर 5 क्वेश्चन, राइट. वहां कुछ डिस्प्ले ना होगा, प्लीज ध्यान से सुनिए आप. राइट, यूर फर्स्ट क्वेश्चन, हेपेरिन इज इफेक्टिव व्हेन एडमिनिस्टर्ड ओरली.
True.
False. -5 marks. An important adverse effect of ACE inhibitor. An important adverse effect of ACE inhibitor is a dry cough. True. -5. Third question. Carbidopa prevents the peripheral conversion of levodopa to dopamine. Carbidopa. Correct. Abciximab. Abciximab is used in the management of osteoporosis. Please use the mic. Please, you should be following some rules. Correct. N-acetylcysteine. N-acetylcysteine is used in the management of organophosphorus poisoning. Your time is up, but I am giving you extra time also. Correct. So you have 3 correct answers, 2 wrong answers. For that, -5 marks will be deducted for each answer, right? Okay. So team C, ready? First question. Benzodiazepines are more powerful cytochrome P450 enzyme inducers than barbiturates.
True.
Huh?
True.
Wrong. Second question. An important adverse effect of colchicine is diarrhea.
True.
Correct. Third question. Omalizumab is used in the management of bronchial asthma.
True.
Correct. Fourth question. Protamine sulfate is used in the management of warfarin overdose.
False.
Correct. Ranitidine is a histamine H1 receptor blocker. वो भाई आंसर नहीं है, करेक्ट बताना है. अरे तो वहां पर काउंट करने का.
True.
Wrong. So you had answered 3 correct and 2 wrong. Clear? Okay. You are 5 questions, right? Let's start. Okay. First question. Verapamil is more better than nifedipine. Please use the mic. Verapamil is more potent vasodilator than nifedipine.
False.
Correct. budesonide is a potent bronchodilator. Budesonide is a potent bronchodilator. True. False. Third question. An important adverse effect of morphine is constipation. An important adverse effect of morphine is constipation. True. Correct. Fourth question. Zolpidem is a benzodiazepine used in the management of sleep disorders. Zolpidem is a benzodiazepine used in the management of sleep disorders.
False.
Correct. Cimetidine is a potent cytochrome P450 enzyme inducer. Cimetidine is a potent cytochrome P450 enzyme inducer.
False.
Correct. So, out of 5 questions, you have answered 4 correctly and 1 wrong. ठीक है? Okay. Let's see the scores. अपना पॉइंट 4 हो गए यार. इसको रब कर दीजिए. रेजर नहीं लिखा? रब कर दीजिए, मैं लिख देता हूँ. दोनों का बीच में टाई है. Okay, announcing the scores. Okay, so team A 40 marks, correct. Team B 40 marks again, right. Team C 50 marks, and the winner for today's quiz is Team D 55 marks. Right. Now, so team D has got 55 first, Team C second with 50. There is a tie between these two teams, 40 and 40. So we need to have a tiebreaker question to decide the third prize. Right? Okay. क्या है? माइनस नहीं है, वो पास कर दिया. पास किया तो 0 होता है. इन्हीं दोनों के बीच में होता है. Okay, so listen carefully. I am going to ask 2 questions here. Right. So based on the 2 questions, if any team is saying 2 correct, then they will get high marks. Okay. So the first question for both of you. Right. So whoever knows, you just raise the or you can use the bells also. You can use the bell, right? Right? Listen carefully. Zoledronic acid. Zoledronic acid is an oral bisphosphonate. True or false? Zoledronic acid is an oral bisphosphonate. What? No, 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 no. It's only correct or wrong, that's it. Huh? Wrong. हो गया, एक बार बता दिया हो गया काम. Right. एक true बता दिया तो false है तो false ही है ना इसमें. Right. Okay. So that question is gone now. Second question. Name one insulin that is given intravenously.
Glargine.
Wrong. हो गया, दो क्वेश्चन तो हो ही गए, राइट? सो लेट्स आस्क वन मोर क्वेश्चन देन, बिकॉज थर्ड के लिए तो डिसाइड तो करना पड़ेगा. द लास्ट क्वेश्चन, इफ यू आर नॉट सेइंग दिस करेक्टली, वी आर गोइंग टू डिवाइड द प्राइज इनटू टू. देयर इज नो अदर ऑप्शन अवेलेबल विथ अस. गोइंग टू डिवाइड द प्राइज इनटू टू, राइट? Right? Let's start. Okay. Clopidogrel is an antiplatelet drug. बताओ.
True.
चलो आसान है इसलिए मार दिया बिल दबा दबा के, राइट? तो इसमें तो हमको वो किसने फर्स्ट मारा, वी डोंट हैव दैट फैसिलिटी टू सी, राइट? ओके, सो लेट मी आस्क यू द सेकंड क्वेश्चन हियर. Dabigatran, dabigatran, dabigatran is a oral factor 10A inhibitor. Dabigatran is a oral factor 10A inhibitor. No? Correct. Okay. So, with this we are concluding the quiz. So, we have team D with the first prize, right? Team C second prize and team A third prize. But overall, it's a very good involvement, very good participation from the students. Right? So congratulations to all the teams. So first, second doesn't matter, right? So you have tried your best. No problem. Better luck next time. No problem, right? Okay. So the prizes will be a certificate for all the members. There is a certificate. You have participated in the quiz competition, right? And apart from that, there is a monetary also, right? Amount we are not going to disclose here. There is a monetary benefit also is there. So the prize distribution will be given at the end of the program, like 1:30. Okay? Okay, you can discuss. Thank you. So now you should be careful. It's not fair. It's no, no, no. It's not fair like that, right? When something is given, you should be, mic use करने का और सही बोलने का.
Chikhalo. Hello, Chikhalo. Chikhalo.
you all. I welcome our chief guest today, Satyana sir, Vice Chancellor sir, Dean sir, Sankalp sir, and Vidya sir, our medical superintendent, and our vice madam, Sewa madam, for this CME program on pharmacovigilance. So, let me give a brief overview of this program. What is it all about? So, this particular week 1981 से यूएस में इसको तो बहुत सारा मतलब विद फुल एंथुसियाज्म से उसको स्टार्ट किया। अब जब इंडिया आया ना, इंडिया आने के लिए बहुत थोड़ा टाइम लगा है इसको। 1986 में, 1961 में स्टार्ट हुआ यूएस में, 1986 में इंडिया ने उसका इनिशिएटिव ले लिया। अब इनिशिएटिव लेने के बाद एग्जैक्टली काम कब शुरू हुआ, यू कैन सी 2010 में। सो 1986 और 2010 यू कैन सी, right? So there is a lot of gap that has been, time has been spent. 2010 में जब शुरू हुआ था तब इंडिया ने कौन सा सेंटर था जो जिसने शुरू किया था इसको, एम्स दिल्ली ने फर्स्ट शुरू किया था इसको। उसके बाद 3-4 रीजनल सेंटर्स को बनाया। देन द प्रोग्राम हैज बीन so then you have very few centers at that time. एक
to create sensitization, to make aware of the public about this particular important program, the government of India is making a schedule to conduct for a week. So we have also taken initiative with in collaboration with the community medicine under the guidance of M.L. Sharma sir. We have conducted certain outreach programs also here. We have conducted at our PHC, we have conducted the program at the CHC also, and we have conducted poster presentations, we have conducted quiz competitions related to this particular program. So to create awareness to the students also, because students are only the guys who are going to become clinicians, so they should have the knowledge from now on. So we have conducted all these programs now. So there is a session on ADR documentation reporting also, and so this is the one study is available. So thank you for giving me opportunity and to actually conduct this program, and I thank the management and the deans around MSR and madam to come here and raise the occasion, and thank you. Thank you.
Thank you so much, sir. We are truly grateful to you for sharing your valuable insights. Now I request our respected Dean, Dr. Santosh Dwivedi, sir, to say a few words about the program. Sir is a great inspiration to us. Sir's remarkable contribution to the medical field has inspired many and continues to make a significant impact. We extend a heartfelt gratitude towards Sir for taking time to be with us today, and we look forward to hearing their valuable thoughts. Please give a big round of applause for Sir.
Good morning to all. Respected Vice Chancellor sir, Medical Superintendent Dr. Kumar sir, Vice Dean Madam Dr. Seema, Assistant Dean sir, Dr. Rajesh, and all the health departments who are sitting here, clinical as well as the other departments, respected faculties, and our professors, associate professors, junior faculty, and my dear students. Organizing this CME on the topic, such a resilient topic, vibrant topic of pharmacovigilance, actually alarms our minds for the alertness, for the disbursement of the knowledge, and very important, but very, very key factor is the orientation, self-orientation, social orientation, regional orientation, and national orientation of all the human beings, those who are dealing with the drugs and medicines and the other counterpart of the therapeutic agents, implants, and procedures even. Why it is important to further extend our contribution, not as a service provider, but more so as a social serviceman. Because treating something, getting the correct material for the treatment of certain diseases, certain illness of the human being, always has some drawbacks or adverse effects of all those materials. So when you are actually dealing with the patient, you have to be very much oriented what sort of material you are taking up for the treatment patient go without continuous follow-up. This orientation, this sensitization makes the whole very society a vigilant one. So what is going on after giving the medicine, after treating the patient, what is going on as an acute reaction, subacute reaction, or chronic reaction, or remote reactions, or the sequelae of any treatment. Paramount important thing is that one life is most precious. Every single life is more precious. And whole of the society of the human being are utmost precious for the growth and development as a nation and as a world. The broader picture comes with one person, one life. In the production of these drugs, implementation of these drugs, adaptations of these drugs, that all these whole very chain should go through the regulatory process, and every one of us should be vigilant. That is why it is called vigilant for what? Vigilant for pharmacological products are the subjects in which these modalities are going to be applied. Rightly so, lot many implants are there in the market. Many vaccines are there. During the COVID period, importance of all these steps, right from innovation to manufacturer to regulator, just 1.5 years or 2 years back, the whole very system is pointing out towards vaccine कब आए, अभी क्या हो रहा है, किस स्टेज में, कोविड से सब डरे हुए थे, अरे वहाँ वैक्सीन पहले आ गई, इंडिया में वैक्सीन आने वाली है, और जब आ गई तो एप्रीहेंशन थे, अरे इससे रेगुलेशन हुआ या नहीं, या रेगुलेटेड और अनरेगुलेटेड, फिर कोई कहने लगा, एक साल के अंदर सारी क्लिनिकल ट्रायल कैसे कर ली, ह्यूमन ट्रायल फेज 1, फेज 2 एंड इवन फेज 3, कि अब लगा रहे हैं ये इसकी वैक्सीन, ये उसकी वैक्सीन, सो मैनी थिंग्स. Ultimately, the science produced that safety cover to all of us. But साइंटिफिक बिरादरी इस बात को लेकर अवेयर रही और आज भी है. एक स्टेज होती है फेज 4 ट्रायल. उनका जो रिसर्च होती है, ये सब कैसे पॉसिबल है? दो चीजों से पॉसिबल. द फर्स्ट थिंग इज रेगुलेशन ऑफ एवरी स्टेप, रेगुलेशन ऑफ एवरी प्रोसेस. रेगुलेट करना होता. सो रेगुलेटरी बॉडी होती है, रेगुलेटरी प्रोसेस होती है, और दूसरा होता है एनालिसिस, डेटा कलेक्शन, डॉक्यूमेंटेशन, prompt, correct mechanism of documentation of every single effect or unwanted effect. of every medicine, every implant or other therapeutic agents. And then the last thing is the evaluation of that data, synthesis of that data, analysis of that data. So फार्माकोविजिलेंस जब गवर्नमेंट ऑफ इंडिया ने 2010 में पीबीपीआई प्रोग्राम अडॉप्ट किया, लॉन्च किया, डॉक्टर राजेश ने अभी बताया, इट स्टार्टेड विद 1 सेंटर और आज ये 950 सेंटर के करीब हो चुके हैं। इन सेंटर्स का मेजर वर्क क्या होता है? रेगुलेशन, रिकॉर्डिंग, एनालिसिस, evaluation, and then contribution in the national policy making. Dr. S.S. Tantia, Institute of Medical College, is perfectly capable to be recognized as one of the regulatory center for this pharmacovigilance activity. As we have got resources, we have got some researchers, we have got faculties, we have got the system. Only thing is the maturation, systematization and maturation of the subject which is needed actually. Of course, every such activity needs licensing. डॉक्टर राजेश हमारे बीच एक बहुत ही ओरिएंटेड, डेडिकेटेड और एक्सपीरियंस पर्सन हैं जो साइलेंटली इस तरफ आगे बढ़ रहे हैं और उनके एफर्ट्स में एज ए डीन ऑफ दिस इंस्टीट्यूट मेरा सारा सपोर्ट है। हमारा मैनेजमेंट इतने कम समय में फार्माकोविजिलेंस के लिए विद इन 2 months ओरिएंट हो चुका है। हमारे एमएस डॉक्टर बिंद्रा रिलेंटलेसली इस चीज को टेकअप कर रहे हैं। जब डॉक्टर राजेश असिस्टेंट डीन बने, उन्हें इंट्रोड्यूस करना पड़ा, लेकिन जैसे ही फार्माकोविजिलेंस को लेके गए, he is a self-introduced personality of our institute. So thank you very much, Dr. Rajesh, for your efforts. मैं इस टॉपिक को लेके आपसे सिर्फ 2 ही बात कह सकता हूं। जितने क्विकली, जितने प्रॉम्प्टली आप ओरिएंट हो सके, जितने प्रॉम्प्टली आप डॉक्टर राजेश को इस सेंटर एस्टैब्लिशमेंट में हेल्प कर सकें, उतने ही जल्दी हमारी इफेक्टिवनेस एज ए सर्विस प्रोवाइडर और स्पेशली फॉर द स्टूडेंट, जो कि हमारे अंडर ग्रेजुएट स्टूडेंट हैं, हमने स्पेशली ये इस तरह से पूरा प्रोग्राम रखा है कि हमारे एमबीबीएस स्टूडेंट इसी स्टेप से, इस सब्जेक्ट से अवेयर हों, बिकॉज दे आर द नेक्स्ट जनरेशन फ्यूचर ऑफ हेल्थ सर्विस सिस्टम ऑफ इंडिया। तो अगर आज से ही वो इस सब्जेक्ट से फैमिलियर होंगे तो मोर इफेक्टिवली दे कैन रिप्रोड्यूस and they can serve to the society and they can reproduce the good, excellent culture of documentation, pointing out all the small things, micro level तक की जो reactions या unwanted effects ह्यूमन बीइंग पे आते हैं, उनके लिए बहुत ज़्यादा विजिलेंट बनेंगे और उनकी इफेक्टिवनेस एज ए डॉक्टर सोसाइटी में बहुत तगड़ी रहेगी। सो थैंक यू वेरी मच फॉर ऑर्गेनाइजर्स एंड थैंक्स स्पेशली टू ऑर्गेनाइजिंग टीम टू इनवाइट मी टू से फ्यू वर्ड्स। थैंक यू वेरी मच एंड गुड लक फॉर दिस प्रोग्राम।
Thank you so much, sir, for your kind words. Now we have amongst us Dr. M.M. Saxena, sir, Vice Chancellor, Tantia University. Sir's main thrust has been towards augmenting and mobilizing human resources for raising academic standards and accelerating the development of Tantia University. to meet the national and international standards. Thank you, sir, for taking out time from your busy schedule to be with us today. Now I request sir to please come on the stage to share a few thoughts regarding the program. Please give a big round of applause for sir.
Thank you very much. I think I am audible without this mic as well. It gives a lot of echo. Am I audible? Shall I use it? Okay, anyway, thank you very much. I'm comfortable with this. Esteemed Dean of the Faculty and Medical College, Professor Dwivedi, Deputy Dean, Dr. Seema, Medical Superintendent, Dr. Bindra, Professor Forensics, this Pharmacology Department and Head of the Department, Dr. Rakesh, learned faculty members, administrative staff of the Medical College. I can name a few and can miss many, so I'm not naming. My dear friends, dear students, whenever I get this opportunity to talk to my fraternity, my students, and have this opportunity to learn a few things, I always accept such kind of invitations, and I feel obliged that you have invited me so that I can learn a few things. I always mention that although I am a institutional head, but in such programs I am an odd man out. I am not a medical practitioner. I am not a medical subject specialist. But indeed, as a layman, whatsoever I can learn from the subject, I just would like to share. Anyway, first of all, I congratulate Honorable Dean and the faculty members for organizing such CMEs. These are a very, very important programs. I am told that this is perhaps 16th or 17th CME being conducted by this medical college, and perhaps I have attended most of them and have at least learned a few things. The subject, that pharmacovigilance, is a very pertinent subject so far as the pharmacology is concerned. Friends, as a layman, what I understand from pharmacology is it is the drug science. It's the chemistry and action, what we study so far as the drugs are concerned. Drugs, when we call, includes a wide spectrum of molecules. Some are used to treat a given problem, some are supplements, and others are for immunity. That's how I feel. And we all are exposed to this or that drug at any given point of time. When we talk of action of a drug, there are all chances that there will be some kind of unwanted actions as well. Not always the drug will hit the targeted cell or the molecule, but at the same time it will hit the non-target cells or molecules as well. So when we talk of vigilance, yes, there is risk, at the same time there is benefit of a given drug, and we'll have to study the balance of these two factors, and that's how we prescribe a given medicine. I recall when I was young boy in early 60s, I was administered penicillin and I was sensitive to it and had a very bad situation. That time there was not a train to test the sensitivity of a given drug, and some antidote was given, And then doctor prescribed to my parents that you put a slip in his neck that he is sensitive to penicillin and he should not be administered this drug in his life. That's how, because that time, that kind of technology was not there that we let us assess the sensitivity first and then administer a drug. Again, there are formulations, this and that combinations of drugs. These combinations are prescribed and tried, and after we see that given a very long time, after 10 years or 20 years, we withdraw a few drugs saying that yes, this combination is not perfect, and these drugs, they are contraindicative, and ultimately the results are not desired ones. We have recently seen in newspapers that combination of 3 drugs for common cold were withdrawn. Even when we were given these antibiotics like amoxicillin and on, doctor used to say that you may suffer diarrhea. Why? Because that drug will hit your intestinal flora, which are useful to you, and at the same time you may have a diarrhea. Yes, that is there, and that they used to say, yes, you'll have to take B complex along. Now, as we look into prescribed medicines, we find, yes, this is contraindicated in such and such situations. It has not to be given to the infants. It has not to be given to the pregnant females. It has not to be given to the lactating females. It has not to be given with alcohol, and so on. So this is how we reach to such conclusions. This is the vigilance, I think, our learned pharmacologists have been doing, that yes, this may cause this much damage and we should avoid such situations. As I mentioned, I am not a man of pharmacology, but whatsoever as a layman I understand the things. There are different methods employed in vigilance practice. There are passive methods, there are active methods, there are comparative observation methods, stimulation methods, at the same time targeted methods. This kind of vigilance we carry out, and at the last, when we talk of these targeted methods, we go in for clinical trials and so on. So yes, whatsoever wisdom today is, we go accordingly. Maybe after 10 years, maybe after 5 years, we have developed lot many other things, and we find, yes, this was okay, but at the same time, this has not to be given beyond this period, beyond this dose. Or at the time, we also withdraw certain drugs. So that is a regular process, and our regulatory authorities, they carry out such kind of practices so as to ensure our health, our immunity, and a situation when we get disease free. So my friends, I may be excused if I have made any wrong comment, because I am not a man of this discipline or medical science, but as a layman, whatsoever I understand, I share. We are running 15 faculties in this campus, and surely I am called to veterinary or law or education or medical, whatnot, and have to learn a lot many things while coming to such faculties. Whatsoever you are delivering, that are all asset to me. I am once again very much thankful to the organizers of this CME that you have given me this opportunity to be here and learn a few things. Thank you very much.
Thank you so much, sir, for your thoughts are so inspiring. Now, we would like to felicitate our respected dignitaries on the dais with a memento in recognition of today's program. So, first, I would like to invite Dr. Rajesh to present memento to our Vice Chancellor, Professor Dr. M.M. Saxena, sir. Please, तालियां नहीं रुकनी चाहिए. Thank you so much, sir. Now I would like to invite Dr. Subhash Vishal Garg to present memento to our Medical Superintendent, sir, Dr. H.S. Bindra, sir. Please give a big round of applause. Thank you so much, sir. Now, I would like to invite Dr. Prabhat Kansal, sir, to present memento to our Dean, Dr. Sankalp Dwivedi, sir.
Now I would like to invite Miss Akanksha Acharya ma'am to present memento to our Vice Dean ma'am, Dr. Seema ma'am. Please give a big round of applause, everyone.
Thank you so much, ma'am. Now, I would like to invite Dr. Akil Hadar to present memento to our HOD, Dr. Rajesh, sir. Please, sir. Thank you so much, sir. With this, we have come to the conclusion of inaugural ceremony. Please give a big round of applause for all of us. Thank you so much. चल नहीं रहा, नहीं सुनाई दिया. Let's have a short break for 10 minutes. Thank you.
I welcome you back, respected delegates, faculty members, my batchmates. Privileged to invite Dr. Rajiv Singhal sir to present the seminar on the topic current area status at Sewa Hospital. But before that, I would like to invite Ms. Akanksha Acharya ma'am for a brief intro. Ladies and gentlemen, can we have a big round of applause?
Thank you, Priyanshu. Welcome back to all of you. Now I introduce Dr. Rajiv Singhal sir. Dr. Rajiv Singhal sir is a distinguished medical professional with over 25 years of clinical experience. He holds an MBBS and an MS in orthopedics from SMS Medical College, Jaipur. Currently, he serves as an assistant professor in emergency medicine at Dr. S.S. Tantia Medical College. Dr. Singhal is also a national faculty member for emergency medicine program at EM Gurukul under the auspices of ACCEE. His contribution to the field include authoring 2 books and securing a patent showcasing his commitment to advancing medical knowledge and practice. Dr. Singhal's extensive experience and expertise make him a valuable asset in the realm of emergency medicine. Please welcome sir. Please give a big round of applause for sir.
इसका वो दे दीजिए मुझे इसका रिमोट. Okay. Hello. Good afternoon all. इको तो नहीं हो रही साउंड? ठीक है, fine. Okay. Now today's topic of seminar is basically to make you understand how the things happen in real clinical scenarios. Like we take now, for example, the emergency medicine department, because it is first line handling department and most of the drugs used there are intravenous, with the chances of ADR are more as compared to oral and other routes. So let us go into deep how we do assessment, manage things regarding ADR in emergency. Definition of ADR, I've seen everybody of you is aware of it. What ADR? Harmful, unintended. Unintended and harmful, we have types of ADRs, you all know. You know all types. There are 7 types, A, B, C, D, E, F types. There are acute, there are chronic, there are some type A which are related to emergency. Type A, augmented, dose dependent and predictable reactions. What does it mean? Like beta blockers, we all know, will cause hypertension. They will decrease BP. If we increase the dose and by mistake or deliberately, unintentionally we give the dose, more dose, is going to be a ADR. It will not be a side effect. Side effect is within therapeutic range. Because allergy. Allergy is quite different and ADR is something different. Because allergy is quite different and ADR is something different. We have to check for it for allergy test. Then how does we recognize ADRs in emergency? Most important and common things is as we give some injection, IV, infusion, there are skin rashes, there may be itching, there may be complaint of some cardiovascular, yani hypertension or hypotension may occur, shortness of breath, nausea, vomiting, dizziness. These are common things that happen. They happen just after starting the infusion or giving some injection. Some are delayed, but most of them just happen within 1 or 2 minutes or 3 minutes. Patient starts complaining, so what we have to do, I'll tell you later on. How to manage ADRs? These are very important steps. First of all, you have to know which drug can cause an ADR. Anything can happen. So first of all, look for unexpected changes in patient's outcome after medication is administered. Ask him if there is something wrong, some rash is there, some inflammation is there, something unpredicted is going on. Then think of ADR. Immediately stop the medication. Immediately stop the IV line, or if you are infusing by injection, stop it. Then stabilize the patient, take vitals, symptomatic treatment, antihistaminics for anti-allergic, IV fluids, or if the reaction is severe, you have to give epinephrine also, and steroids also. These are the basic things you can do in an ADR status. And the most dangerous ADR is Stevens-Johnson syndrome. You must have read in your book. It is the most serious, and it can lead you to ICU, and eventually only 30–40% patients survive if this happens. Anaphylaxis, I have told you, epinephrine, antihistamine, steroids, hypertension, vasopressors and IV fluid, seizures, benzodiazepines, anticonvulsants we have to give. These are for stabilizing, management of patient having showing ADR. We have to stop the drug. Now important thing is what to do after that. If we talk about the treatment, we can change the drug, safer drug, because we have to continue the treatment. We can't leave the patient after ADR, we have to change the drug. For example, if antibiotic cefotaxime has done something, we can give some other, ciprofloxacin. We can change the antibiotic. Similarly, we can change the drug. This is the management part. But the important part is, what should we do? How should we, you will be knowing in workshop how to report this incident that something has happened which was not expected after starting infusion or after giving drug. So, documentation is very important, in which we have to, you will be told what things have to be written, and this is called internal reporting of pharmacovigilance. We have to do only internal pharmacovigilance. We have to fill the form, give it to the person who is in charge of the committee or the staff. They will just submit it, and like Dr. Rajesh and they are the head of the committee, they will just go through it and address the purpose. Now, I'll tell you about what are the common ADRs which we are facing at Sewa Hospital. This is basically underreported. The reactions and the common causes are more, but what we have documented, we are showing you. This is one of the most common ADR that we see in emergency, mild phlebitis, IV site reaction. And it is caused by most commonly ceftriaxone, potassium chloride, phenytoin like drugs. These are common drugs which we associate, and we are careful. Why? How we know that these drugs generally can cause phlebitis? When we give them IV cannulation करते हैं, उसके बाद ये drug देते हैं, तो these can cause. We know, so we are careful. And if they cause phlebitis, we just, symptoms are red, warm, mild pain at IV site, then we immediately stop the infusion, apply warm compression, rotate the IV site. That's all. In these drugs, if there is mild pain and redness, we don't have to think it's a serious ADR. We just change the site and restart and check. It will be fine. Extravasation of IV fluid. Some drugs are like cefazolin, non-vesicant fluids. They cause localized swelling if there is extravasation in the tissue. IV cannulation में अगर vein से थोड़ा सा leak हो जाए, तो that can cause a swelling, discomfort, redness. उसमें भी you have to stop. It is a medication error also of what type of psychomotor, यानी आपने उसको लगाने में कैनुला गलती की है, वो भी हो सकता है, और कई ड्रग ऐसी हैं जो आपने लगाया सही है, but still they can extravasate. So stop infusion, elevate the limb, applied cold complex, that's all. उसके बाद आप उसको दूसरे लिम्ब में प्रॉपर तरीके से उसका कैनुलेशन करके you can start it. Mild allergic reactions, contrast agents जो हम CT कराने के लिए, MRI कराने के लिए contrast agents देते हैं, जो हम इमरजेंसी से उनको तैयार करके जाते हैं, या फिर इमरजेंसी में हम पेशेंट को तैयार करते हैं और रेडियो डायग्नोसिस में जाके उनको सीटी के टेबल पे हम उनको आईवी कंट्रास्ट सीटी में देते हैं, तो उस समय ये रिएक्शन बड़े कॉमन है, इचिंग, माइल्ड रैश, लोकलाइज हाइव्स. तो उस समय हमें अपने पास क्रैश कार्ट रखना पड़ता है. वी हैव टू स्टॉप द इन्फ्यूजन, एडमिनिस्टर द एंटीहिस्टामिनिक. एंटीहिस्टामिनिक्स you must be knowing. Okay. Transient hypotension. This is very common in some drug. बीटा ब्लॉकर में तो कॉमन है ही, नाइट्रोग्लाइसरीन में कॉमन है, मॉर्फिन तो अब हम यूज़ नहीं करते, पर इट यूज टू बी वेरी कॉमन इन मॉर्फिन ऑल्सो. इसमें क्या लगेगा, हाइपोटेंशन होगी तो अचानक से लाइट हेडेडनेस, डिजीनेस, बीपी तो आप चेक करोगे तो नीचे होगा. इसमें भी सेम आईवी फ्लूइड और स्लो इन्फ्यूजन. इन्फ्यूजन स्लो करनी है, इसमें हटाने की जरूरत नहीं है, आप पहले स्लो करें उसको. अगर उसको सिर्फ डिजीनेस लग रही है तो स्लो द इन्फ्यूजन रेट को स्लो कर दीजिए. अगर वो उसके बाद उसका सिम्टम साइन चला जाता है तो देन कंटिन्यू स्लोली. इंजेक्शन साइट पेन. सम ड्रग्स आर known for injection site pain.
IV पोटेशियम क्लोराइड, सम एंटीबायोटिथ्रोमाइसिन बड़ी कॉमन है। इसमें भी सेम है, वही इन्फ्यूजन को स्लो कर दीजिए, थोड़ा वार्म कंप्रेस कर दीजिए या फिर चेंज द साइट। दीज आर कॉमन ADRs that we day to day see. We don't see many anaphylaxis reaction or like Steven Johnson or blister that we don't see. I have not seen in a year in our setup. This is how we record the data to fill the ADR form. This is not as per record of the ADR filling form, but this is the data we collect so that we can fill the form or somebody else can fill the form. Like we have to know what is the case. We don't reveal the name generally. We only write the UHID number, ADR, what type of ADR it was, then date and time, age, gender, drug, which was the cause, then what were the symptoms, and how it was managed. Like, for example, somebody was given IV ceftriaxone, and 45-year-old male, and he developed phlebitis. There was redness, warmth, mild pain at IV site. We stopped the infusion, apply warm compress, rotated. IV site means अगर वो लेफ्ट हैंड में थी तो हमने राइट में कर दिया, या डॉर्सन में थी तो वोलर में कर दिया. एंड एजुकेट द पेशेंट का क्या मतलब हुआ? एजुकेट डिड द पेशेंट, यानी उसको बता दिया. पेशेंट को आपको बताना जरूरी है कि दिस रिएक्शन इज डन, दिस इज अ एडवर्स रिएक्शन. हमें भी नहीं पता था, ये हो जाता है, नॉट सीरियस. पर अब आगे से आपको ध्यान रखना है कि अगर एरिथ्रोमाइसिन ले रहे हो जिस ड्रग से भी है तो बी केयरफुल, आप अपने इसमें नोट कर लें. उसको एजुकेट करना पड़ेगा आपको उसके बारे में, बिकॉज समटाइम्स इट बिकम्स अ वेरी डिफिकल्ट टू मेक पेशेंट अंडरस्टैंड व्हाई यू आर चेंजिंग द साइट, व्हाई यू आर चेंजिंग द एंटीबायोटिक. यू हैव टू एक्सप्लेन, डोंट हेजिटेट इन एक्सप्लेनिंग. इसी तरीके एक्स्ट्रावाजेशन का एग्जाम्पल है. 60-year-old फीमेल गिवन IV एमियोडोरॉन, swelling, mild discomfort at site, infusion was stopped, limb elevation was done. Now, in this I have written photograph the site for documentation. How does it important? अब डॉक्यूमेंटेशन करने में खाली रिटर्न में भी कई बार हमें प्रूफ चाहिए होता, तो वी ऑल्सो टेक रिकॉर्ड्स. ये क्लिनिकल के लिए भी हमें काम आता है. वी टेक अ फोटोग्राफ इफ देयर इज अ विजिबल एक्स्ट्रावाजेशन, सो वी टेक अ फोटोग्राफ ऑफ द. नाउ माइल्ड एलर्जिक रिएक्शन आपको बताना पड़ेगा. अगर आप अल्टरनेट एंटीबायोटिक ले रहे हो तो पेशेंट पहले एंटीबायोटिक ले आया, अब वो आप माइल्ड रिएक्शन हो गया उसको, आपने एंटीबायोटिक चेंज कर दिया. इट इज़ नॉट सो इजी टू कन्विंस अ पेशेंट टू, पहले उसने पैसे खर्च कर दिए, 700 रुपये की एक एंटीबायोटिक आ गई, उसमें जैसे ही स्टार्ट किया आपने और उसको ADR हो गया. नाउ यू आर स्टॉपिंग इट एंड आस्किंग कि भैया ये 2000 वाली दूसरी ले आ. तो यू हैव टू एक्सप्लेन, यू हैव टू अंडरस्टैंड, बट पेशेंट को बताना पड़ेगा आपको, तभी वो लेके आएगा. ये मेटोप्रोलोल के साथ फ्रोसिमाइड, लेसिक्स के साथ बड़ा कॉमन है. BP एकदम ड्रॉप कर जाता है, इट्स वेरी कॉमन. अगर हम फास्ट पुश कर दें तो इट जनरली हैपन्स, तो स्लो करना है इन्फ्यूजन इसमें. तो दिस इज कॉमन थिंग्स वी फेस इन इमरजेंसी. नाउ दिस इज आवर डाटा, कंसोलिडेटेड डाटा इन इमरजेंसी. In almost about 10 months of since I am working, there have been 27 cases of adverse reactions managed in the department only. The ADRs were classified into 7 prime categories: phlebitis, IV phlebitis, extravasation, mild allergic reactions, transient hypotension, injection site pain, IV induced nausea, mild dizziness. इसमें मैंने blood के reactions नहीं लिए. The reactions to the blood products I have not taken. Otherwise, they also come into ADR basically. Additionally, there was complex cases like phlebitis combined with mild rash, extravasation alongside injection site pain. Mild. There was no complicated anaphylactic reaction we have seen. And we also take care when we give some antibiotics or some drugs which are known to cause allergic reactions, we do a sensitivity test. AST, we are supposed to do it. So, what are what are our key observations for 1 year in emergency department? Phlebitis was the most common cause encountered in ADR in our department, with antibiotic like ceftriaxone and levofloxacin. this might reflect the high usage of these antibiotics in acute care settings. You understand why this is common? Because we mostly ceftriaxone और levofloxacin बहुत commonly हमारे यहाँ use होती है, तो इसलिए maybe phlebitis is most. Extravasation occurs frequently with potassium chloride, amiodarone, calcium gluconate, और ये भी which are prone to causing tissue damage if they leak outside the vein. So outside the vein leak कैसे होगा मैंने बताया, it can be manual, हम गलती से पंक्चर कर दें वेन को, या फिर कई बार प्रेशर हो जाए, फास्ट पुश कर दिया तो वो एक्स्ट्रावेजेशन हो जाएगा. Mild allergic reactions were reported frequently with antibiotics and antifungals like penicillin G and amphotericin B. तो इनको हम देते हुए थोड़ा सा क्लोज मॉनिटरिंग रखते हैं पेशेंट को, क्योंकि वी नो दैट दे कैन कॉज ADRs. Then transient hypertension was common with cardiovascular medication like nitroglycerin, diltiazem. So उसमें भी हम मॉनिटरिंग करते हैं. तो this was because we have to make our policy also. Pharmacovigilance means internal pharmacovigilance and the pharmacovigilance reporting to the committee. Internal pharmacovigilance means we understand that these kind of reactions we are facing, these drugs are the culprits, so be careful. So we make our policies according to this. This is role of each individual department. Now, what are our recommendations from our department? That you have made beautiful charts. All of the charts are very good, and they were, finding ways out how to improve ADR reporting. What is ADR, and what are the symptoms, and how to improve more reporting, encourage. So, education and prevention. Now, not only educating doctors, staff, and patients. It is very important to report early, so that steps can be taken at the local level. And secondly, you have to tell doctors, for example, in our hospital, or if I am using somebody, Pharma A company's antibiotics, and it is causing some kind of reactions. So I become afraid. I am not afraid. I say, यार मेरी कंपनी बदनाम हो जाएगी, मैं इसकी कंप्लेंट करूँगा. तो आई जस्ट इग्नोर, दिस इज नॉट गुड. आप उसमें डर नहीं होना चाहिए, क्योंकि आपका नाम कहीं नहीं आएगा. आप ADR कोई भी डॉक्टर हमारे डिपार्टमेंट का अगर रिपोर्ट करता है, तो हम लोग सीधा उसको उसके लेवल पे जाकर कंपनी से बात करके उसके ड्रग के बारे में बताते हैं. तो उसमें हम डॉक्टर का इन्वॉल्वमेंट नहीं होता. कई बार डॉक्टर्स को ये लगता है, स्टाफ को लगता है कि मैंने एक पर्टिकुलर एंटीबायोटिक के ब्रांड के बारे में बता दिया कि इसके बारे में ADR, क्योंकि इट्स अ वेरी सीरियस इशू. अगर कोई ADR एक ड्रग, हमारे यहाँ हुआ था मेरे ख्याल सर, हमारे NS सर बैठे हैं, हमारे पास एक बैच RL का बैच, थोड़ा सा पता नहीं कैसे क्या हुआ उसमें, एक बैच RL का ऐसा आया, not in emergency but in wards it was causing many ADRs, mild ADRs. So that whole batch was removed by the company and replaced, but it was a serious issue for that company. हो सकता है उनका बंद ही हो गया हो, वो प्लांट ही बंद हो गया हो. So these are serious things. Sometimes doctors avoid doing this. So we have to teach doctors. Reporting ADR should be thoroughly documented. आपको चार्ट दिखाएंगे वो कैसे भरा जाता है, simple. This will help in monitoring the recurrence and the future treatment planning. This helps us. कौन सी ड्रग क्या कर रही है, जैसे सर ने बताया acute, हम तो acute ही देखते हैं. We can, क्योंकि पेशेंट हमारे पास 4 घंटे रहता है सिर्फ. So we can manage only acute, और पेशेंट फॉलोअप के लिए भी नहीं आता. In emergency, you can manage acute and subacute. You will see ADRs, but in OPD, you will see chronic follow-up cases of ADRs also. Now, close monitoring of high-risk drugs like potassium, मैंने बताया, potassium chloride, amiodarone should be monitored. हमें जिनके बारे में पता है, we have to monitor them. Allergy documentation is important, like in penicillin, you all know. And follow-up care. For example, follow-up care, why follow-up care has come here? Why, what to do with pharmacovigilance? पेशेंट को आपने इतना तो जज कर लिया कि पेशेंट को फ्लीबाइटिस हो गया, थ्रोम्बोफ्लीबाइटिस, यानी जानते हैं ना, जब आपकी यहाँ पे स्वेलिंग हो जाती है, वेन हार्ड हो जाती है, आप थ्रोम्बोफॉर्म ऑइंटमेंट भी यूज़ किया होगा बहुतों ने, कई बार आप करते हो, तो उसका ट्रीटमेंट भी तो आपको पता होना चाहिए ना. तो फॉलोअप करना है उसने, उसको अवॉइड नहीं किया. पेशेंट का आया भी, इसका ADR रिपोर्ट लिख दी, आपका काम खत्म. नो, यू हैव टू कॉल हिम बैक एंड टेल देम द ट्रीटमेंट ऑल्सो टू कम फॉलो. तो आपको अपना जो ADR का साइड जो हुआ है, बिकॉज इट इज हार्मफुल, ADR इज ऑलवेज डूइंग सम काइंड ऑफ हार्म टू द बॉडी. और जो सिंपल हार्म है, जैसे वॉमिटिंग है खत्म हो गया, डायरिया है खत्म हो गया, दैट्स ऑल. बट रैश हो गया, phlebitis हो गया, extravasation करके swelling हो गई, you have to treat that. So this was a brief about how to do pharmacovigilance internal in a department. Thank you. Any questions?
So it's a very good experience, I can say, from the sir's point of view, that जो सर देख रहा था हॉस्पिटल में जब पेशेंट को ट्रीट करते समय इमरजेंसी मेडिसिन में जब भी पेशेंट आता है, ये सिर्फ एक डिपार्टमेंट का इतना ऑब्जर्वेशन है. आप सोच के देख लीजिए, अगर हॉस्पिटल में हर डिपार्टमेंट में अगर ऐसा ही ऑब्जर्वेशन चलता रहा तो कितना केसेस मिल जाएगा. एंड वन मोर थिंग इज दैट जब भी इमरजेंसी मेडिसिन में जब भी पेशेंट आता है तो वो ओनली फॉर ए ब्रीफ टाइम होता है वहां पर. वहां उनका प्रॉब्लम जब ठीक हो जाता है ना, वो शिफ्ट हो जाता है. इधर द पेशेंट कैन गो टू विल बी शिफ्टेड टू वार्ड और विल बी शिफ्टेड टू आईसीयू, राइट. सो वहां कम टाइम रहता है. अब कम टाइम में जो मेडिसिन देते हैं मोस्टली इंजेक्टेबल्स देते हैं उनको. अब इंजेक्टेबल्स से रिएक्शन जो भी होता है वो इमीडिएट होता है. टैबलेट से थोड़ा देर के बाद हो सकता है, बट इंजेक्टेबल से उसका रिएक्शन इमीडिएट आता है. किसी पेशेंट को आपने लेट से डाइक्लोफिनैक है, वो मोस्टली इंट्रामस्कुलर देते हैं, अब इंट्रावीनस दे दिया बाय मिस्टेक किसी को, वो कोलैप्स हो जाता है उधर ही, राइट. सो वी शुड बी वेरी केयरफुल बाय मैं किस सेटअप में काम कर रहा हूं. आईसीयू में काम कर रहा हूं तो व्हाट टाइप ऑफ एडवर्स इफेक्ट्स आई कैन एक्सपेक्ट फ्रॉम द पेशेंट्स. वार्ड में काम कर रहा हूं तो वो एक आइडिया हो जाएगा ना, तो इट विल बी वेरी गुड. मैं डर्मेटोलॉजी में काम कर रहा हूं तो कौन सा आ सकता है उस पेशेंट्स के लिए. सो दैट इज वेरी वेरी इंपॉर्टेंट. एंड वी आर वेरी थैंकफुल टू सर फॉर कम समय में सर ने जो अपना जो एक्सपीरियंस को प्रेजेंटेशन किया है, दैट इज रियली अप्रिशिएट करते हैं हम अपना डिपार्टमेंट से. एंड वी रियली थैंक यू सर फॉर गिविंग प्रेजेंटेशन हियर. बी अ पार्ट ऑफ फार्माकोविजिलेंस. थैंक यू वेरी मच. एक मिनट सर आपको
Thank you so much, sir, for sharing your valuable thoughts. Now I request Dr. Rajesh to present memento with certificate as token of gratitude to our guest speaker, Dr. Rajiv Singhal, sir. Please, sir. Thank you so much, sir. Okay, now I would like to invite our next speaker, Dr. Akil Haider, sir, who is excited to share his insight and facilitate meaningful discussion on current area status of Sewa Hospital. Dr. Akil Haider is our department's young assistant professor who is enthusiastic and diligent about his work. His proactive academic personality stems from his graduation from Government Medical College, Patiala, and his post-graduation from Postgraduate Institute of Medical Education and Research, Chandigarh. He has been a member of various committees in his academic career. Now, please welcome sir. Please give a big round of applause for sir.
Thank you for the introduction, Akansha. So, good afternoon, everyone. Before I begin, I would like to thank the esteemed management, Department of Pharmacology, delegates and students who have made this idea of celebrating pharmacovigilance into a reality. I would also like to thank our Head of Department, Professor Rajesh sir, for giving me this opportunity to speak on the assigned topic. With that, I shall start on to the topic of documentation and reporting of ADRs, adverse drug reactions. Okay, so these two persons carry the highest or heaviest burden on their shoulders. On the left hand side, Dr. Raghuvanshi, who is the director for IPC, Indian Pharmacopoeia Commission National Coordination Center at Ghaziabad. So this is the IPC building, just to show you guys. And then he is the director for Uppsala Monitoring Center, which is at Sweden. Okay, his name is Dr. Peter. So everything reports to Dr. Raghuvanshi at national level and to Dr. Peter globally. Okay, so before we dive into topics, few terms. CDSCO, okay, this was a question in your quiz. Center Drugs Standard Control Organization, which is a regulatory authority for approving any drug in this country. Then IPC, Indian Pharmacopoeia Commission, National Coordination Center, PVPI, National Program for Pharmacovigilance. AMCs are ADR monitoring centers. And Vigiflow is the software in which we report our adverse drug reactions. And then what is Vigibase? Vigibase is the culmination of national softwares. Okay, so Vigiflow is the national reporting software, Vigibase is WHO's ADR reporting software. And then pharmacovigilance has been defined earlier, science and activities related with the detection, assessment, understanding and prevention of adverse drug problems. So just a journey of a drug approval so that you can understand what is signal detection. So as you know that there are 4 phases to a clinical discovery of a drug, phase 1, then 2, then 3, then 4. See, there is a difference between adverse event and adverse drug reaction. We need to have causality assessment. What does it mean? That we have some proof that this drug has caused this adverse drug reaction. Only then we will call it adverse drug reaction. Till we have a proper proof that we can label this as adverse drug reaction, we are going to call it adverse event. So we keep on discovering discovering adverse events in phase 1, 2, 3 and 4. Once we know after the causality assessment, that is proofing of association of adverse event with the drug, then we call it adverse drug reaction. So phase 3 is when the drug gets approved by this organization CDSCO in our country. Now SPC means summary of product characteristics. Whatever adverse drug reactions are found after these 3 clinical trials after these phases of clinical trials, that adverse drug reactions or reactions will be notified in this summary. But what happens? Not all adverse drug reactions or adverse events related to this drug will be detected in such a short number of people and short span. That's why we have phase 4 clinical trial, pharmacovigilance program. So what is signal detection? Signal detection means detecting the adverse events which ultimately will be adverse drug reactions which were not recognized or which were of lower frequency earlier. New drug in case of Indian literature is called within the 4 years of approval of drug by CDSCO. So new drug is a new drug till 4 years of its approval. So we need pharmacovigilance program because not all adverse drug reactions are detected in this till phase 3. Unknown, unrecognized and serious adverse drug reactions. So what are the ADR reporting tools available? One is this mobile application, ADR PVPI, Adverse Drug Reaction Pharmacovigilance Program of India. Okay, this is available on Android phones and I think Mac as well. So next is the helpline, toll-free number you can call between the working hours of IPC from Monday to Friday. Then you have ADR reporting form, which should be filled by healthcare professionals, be it dentists, physicians, pharmacists or nursing staff. And then you have adverse monitoring centers where this ADR reporting form would be reported and validated. Now this is a snapshot from IPC website, Indian Pharmacopoeia websites. So we have different kind of reporting forms. One is adverse drug reaction reporting form for a healthcare professional, version 1.4. So this needs to be filled by physicians, dentists, pharmacists and nursing staff. Then adverse drug reaction reporting form for consumers are also available in different languages. Then IPC has also launched suspected adverse drug reaction form for COVID drugs. And then serious AEFI, adverse event following immunization, is also available among different kinds of ADR reporting forms. Now this is just the adverse drug reaction which is to be filled by a consumer, i.e. non-healthcare professional. This is called medicine side effect reporting form. Okay, it is available in multiple vernacular languages. And the email for this kind of reporting by consumer is different than which is provided for the healthcare professional. Now this is a snapshot of this suspected ICSR form, individual case safety report. I will be showing the first half of it. So Vinodji, forms. Okay. So I will be explaining the different parts of this form so that we can efficiently report this form, or fill that and then report. Initial case, what do we mean by initial case and follow-up case? Initial case, let's say you have an ADR today, you will fill it as initial case. Let's say the patient has not recovered or some lab results are pending. Then, and with each reporting of ADR, a unique ID is created. But if something is pending and you get those details after some time, for example, let's say a week or two, then you again file up a report in the Vigiflow, which is a software, as follow-up case. Then patient initials, okay, we have to just write the initials on this form, or you can write unknown or privacy in case of Vigiflow, so to maintain the confidentiality of patient. Again, age or date of birth, gender, weight. Then B part is suspected adverse reaction. Focus on this, we are not calling it adverse drug reaction because we do not have proof yet. Until we do the causality assessment, meaning establishing the proof that this event has been caused by this drug, only then we will call it adverse drug reaction. That is why this form is called suspected adverse drug reaction reporting form. So you will note down the event or reaction start date, probably with the day, month, year and time, and then event reaction stop date. For example, the rash was produced because of, let's say, an antibiotic today at noon, and then when did and then how long will it take to resolve the rash, for example a day or two or a week. You write those timings in 0.5 and 0.6. Then describe the event management with details if any. So this patient diagnosed with this disease, for this indication this drug was given, in what formulation, through what route, at what dose. You will write in this, and after how long the adverse event started and what was done to manage that particular adverse event. So next is this suspected medications. What medication or medications are suspected to be causative for this adverse drug reaction or adverse event. So you will note down the name, both generic and brand name, and then manufacturer, pharmaceutical company, batch number, lot number, expiry date if known, and then dose, what was the dose which was given, route, with what route, frequency, how many times a day or week, then therapy dates. So this drug which we are suspecting for adverse drug reaction, when was it started and when was it stopped, and it was given for what indication. Then causality assessment, this I'll explain in a bit. So you might have more than one suspected medications, and let's say if you have more than 4, then you use a separate page. And then action taken after reaction. What did we do as a physician or healthcare professional to deal with this adverse event? Did we stop the drug? Did we increase the dose, decrease the dose, or did we not do any change in dose? We did something else, or we do not know what happened. So this is called D-challenge. And over here, point number 10, this is called re-challenge, where you introduce the suspected medication again to see whether this drug is going to cause again the same adverse drug reaction. But some says this is bit unethical in few cases. So this is not routinely done. Unnecessarily pain to or discomfort to the patient. Then concomitant medications. Let's say patient is taking metformin, which is a suspected medication, but patient is also taking antihypertensive medication. So you can add other drugs which the patient is taking as concomitant drugs, and you will write the dosage parameters in these as well. Then additional information, if there was not enough space in the event description, then you can write over here. Then reporter details, okay, this is to be mentioned. These are the mandatory parameters like name and address, PIN code, email, contact, occupation, signature, and date of reporting of that particular adverse drug reaction. So and you should, point number 12, always add relevant investigations with dates if they are available, and relevant medical or medical history. For example, patient had a history, known history, allergic history to few drugs or a drug, or relevant diagnosis. For example, hepatic derangement, liver, renal derangement, or any special population like pediatrics, pregnancy, geriatric. Now focus on this point, seriousness of the reaction. Seriousness is a terminology which we use in Pharmacovigilance program of India in reporting this adverse drug reaction. Severe, mild, moderate, severe. These are different grades which we assign to a diagnosis or disorder or disease. Over here, PVPI has used the seriousness of reaction. It could mean that the patient, let's say, has died because of the drug, or patient had a life-threatening adverse drug reaction, which means there was a real risk of death, or the hospitalization. If the patient was already admitted, the total stay of that particular patient was prolonged because of adverse drug reaction, or if the patient was not hospitalized but because of ADR patient needed to be hospitalized. So the other parameter which could be included in serious adverse drug reaction, that pregnant mother has taken a drug and baby has been born with the congenital anomaly. There could be a disability which could be persistent, permanent, significant because of that suspected medication. Other medically important, and you will write down in the outcome whether the patient recovered because of that drug or of that particular ADR, whether the patient is still recovering, any permanent damage, recovered with sequela, whether it was fatal, not recovered, or unknown. So focus on the right top part of it. This is for AMC, NCC use only. AMC means Adverse Drug Reaction Monitoring Center, and NCC National Coordinating Center. So you will write based on the presentation to ward OPD, you will write the IPD number, inpatient number, outpatient number or case registration number of that particular case. AMC report number, once you enter the data with its completeness into the VigiFlow, this adverse drug monitoring center will create a reporting number which will be unique to that particular adverse drug reaction. And then once the data is uploaded to the National Coordination Center, then worldwide unique number will be generated. So this is how we report the suspected adverse drug reaction in this reporting form. This is to be again filled by healthcare professionals. Now, how do we prove that this suspected adverse event was caused by this particular drug? We have several assessment scales, causality assessment scales. Most commonly used are WHO UMC scale and Naranjo scale. Naranjo scale is from University of Toronto, and this is in collaboration with WHO and Uppsala Monitoring Center. So, see, when we say that we are detecting a signal in terms of suspected adverse drug reaction, we start from the possible. Most adverse events are due to drug are possible or probable. So whenever you are doing causality assessment, you start with possible and then you upgrade based on the information or downgrade based on the information. As you can see, there are several criteria. See, these are the gradings: certain, probable, possible. They are basically just means that we are this much confidence in certain. When we are calling that this drug has caused this adverse event and we are certain about it, it means that we are 90% confident. We are not 100% confident, or maybe more than 90. Over here, probable 70 to 80 or 80 to 90, and possible, like we are less confident. So confidence decreases as we move from certain to possible. And how do we give these grading to a particular suspected adverse drug event? We will see whether after giving a drug there is a timeline after which the adverse event started. And plausible means believable. See, when we call it probable, the terminology used by this scale is reasonable. Again, there is a decrease in confidence. Over here, reasonable. And then this adverse event cannot be explained by disease or other drugs. So, and then response to withdrawal, plausible. When the drug was withdrawn, the adverse event started resolving. Again, these are the parameters on which we are going to show the association with what percentage of confidence, and we will say that we are this much confident in saying that this is the adverse event because of this drug or these drugs. So I thank Dr. Kansal for sharing this suspected ICSR. So this is a 40 years old female, Sita Devi, 56 kg, was prescribed tablet clozapine, which is an atypical antipsychotic, 50 mg twice daily. For negative symptoms of schizophrenia. After taking clozapine for 2 weeks, her blood investigation showed that she was having neutropenia. And what was the management? Clozapine was stopped and the patient was on daily observation for ANC, absolute neutrophil count, and the patient has shown improvement in the absolute neutrophil count. And based on these findings, like manufacturing detail, expiry date, batch number, tablet brand, the company's name, these details are given. So you will fill, based on these findings, this form which I have just explained to you. These all things, whatever details are not available, you can leave, okay, and this will be filled as initial case. So thank you. Any queries? None?
Yeah, thanks Akhil. That was a nice and brief information related to different types of causality assessment. The one problem that that arises again and again related to the ADR or the pharmacovigilance is if a particular doctor is giving some medication to the patient, and if that because of that particular medicine, if the patient is getting some problem, doctor will be thinking that because of my treatment the patient is getting a problem, so if I report it, a case will be registered on me. Because of my doctor will be thinking it is his mistake, that is why patient is getting the problem. So doctor should be confident enough to say that it is not his mistake, it is the mistake of the medicine. That confidence should be there in the doctor. Then only he can report it. Otherwise, will always a fear will be there. Due to my treatment only patient is getting a problem. Right. And to clear this fear away from the doctor, if you find, you just show the slide, the down instructions. Yeah, just show that. Yeah. So, और थोड़ा पीछे चाहिए, जरा जिसमें क्रॉप करके रखा था आपने. Yeah, if you see the last sentence of this document, आपके document में भी last sentence पढ़ो, जो document दिया था. I want the students to read it. What is given? The last sentence. Say loudly. What is the last sentence in the? Huh? Last में last sentence क्या है? इधर आजा तो देखो माइक ले लो, माइक लेके बताओ रिपोर्ट में क्या होता है, माइक लेके बताओ.
Submission of an ADR report does not have any legal implication on the reporter.
सब सुन लिया? आप रिपोर्ट करेगा तो वो लीगल स्टेटस नहीं बनेगा, ये आपके ऊपर नहीं आएगा केस. इट विल बी डिसाइडेड बाय द PVPI whether to accept that report or not. That's it. Nobody will file a case on you that you have reported like this. Right? So, it should be, you should educate the patients, you should educate the consumers also, that by taking any medicine, suppose if a medicine like a paracetamol, which is considered as a safe drug, might not have caused any ADR in thousands of patients, but we don't know, each individual genetic variability is different, due to which even a person, even my close relative of my family is having allergic to paracetamol. Just think about it. Paracetamol से allergy है उनको. अब fever आएगा तो क्या लेना है उसको? Right. So, the educating the customer or educating the patient is very important. We need to tell them that this drug is safe, but it may cause some adverse effects. This sentence is must. Otherwise, you will have a fear that the patient will file a case. By saying this, you are on the safer side. I informed the patient about this. That is very important. Right? Okay, thank you. Thank you very much. Just a minute.
Please give a big round of applause for Sir. Now I would like to invite Dr. A.D. Parekh Sir to present Memento with Certificate as token of gratitude to our speaker, Dr. Akil Haider Sir. Thank you so much, sir. Now we are moving on the prize distribution ceremony. For that, I would like to invite our Vice Dean, Dr. Seema Ma'am, to hand over the prize of quiz competition to the students. Please, ma'am, come on the stage. Please, ma'am. Firstly, I would like to call Yajat and Piyush to collect the participation certificate for the quiz competition. Please, students, come on the stage. Now, the third prize of quiz competition goes to Jyotsna and Sanya. Please तालियां बजाते रहिए. Now, envelope. Envelope साथ में देना है. Second prize goes to Atul Yadav and Priyanshu Kaushik. Please, students, come on the stage. Yes. Now, first prize goes to Paras and Vinona. Please, students, come on the stage. Please give a big round of applause for all our winners. Okay. Thank you so much, ma'am. Thank you, students. Now, I would like to invite Dr. Amal Sharma, sir, to hand over certificates of poster presentation to our students. Please, sir, come on the stage. आइए सर. सर कैसे बोलूँगी सीधा? फर्स्ट पोस्टर प्रेजेंटेशन.
And his team, please.
First team, Aditya and his team, please come on the stage. Aditya Upneja and his team. सर्टिफिकेट्स ले आओ. Next. Yes, next, Joshna Singh and her team.
Please come fast.
Please come fast. Next, हर्षिता और उसकी टीम रेडी रहे. सारे एक साथ.
टीम एक बार चला जाए.
Next, Chirag Goyal and his team, ready rahe. Chirag and his team, please come on the stage. Next, Vinona and her team. आगे जाओ, आगे थोड़ा सा उधर हो जाओ, तो उस तरफ चले जाओ. Next, Vinona and her team. Yes, next, Harshita, Jia, Kunal and Muskan. Yes, one more. Harshita, Jia, Kunal and Muskan, please come on the stage. Next, Ishika, Hitanshi, Vibhuti and Amita. Please तालियां बजाते रहिए. Okay, Ishita. Yes, next, Vanshika and her team, please ready. Vanshika and team, please come on the stage. Next, and the last group, Reva and her team, please come on the stage. Please give a big round of applause for all our participants. Thank you, sir. Please, sir. Now, I would like to invite Dr. Rajesh on the stage to present memento as token of gratitude to our Professor Dr. Amal Sharma, sir. Thank you so much, sir. Now I would like to invite Dr. Subhash Vishal Garg for vote of thanks of this program. Please, sir, come on the stage.
Audible. Thanks, Ms. Akanksha, for providing me this opportunity. It's a tough decision for me whom to thank first, but two names are very clear in my mind. First of all, the Almighty God, who has given us the opportunity to serve the mankind, and secondly, Dr. S.S. Tantia, whose vision made us here today, and the institute is in the shape. Thirdly, I would like to thank to Dr. Mohit Tantia and the whole management team. We see the success, but we don't see the efforts behind it. So it's a great efforts they are putting day and night. After that, I would like to thank the authorities who visited in our inaugural section. Dr. M.M. Saxena, Vice Chancellor, Principal or Dean, Dr. Sankalp Dwivedi, M.S. Bindra Sir और H.S. Bindra Sir जो हमारे मेडिकल सुपरिटेंडेंट हैं, और स्पेशल थैंक्स टू वाइस डीन मैम जो अभी तक हमारे साथ बनी हुई हैं, जिन्होंने हमें पूरा समय दिया. और अपार्ट फ्रॉम दैट स्पेशल थैंक्स गोज़ टू कम्युनिटी मेडिसिन डिपार्टमेंट, जिन्होंने काफ़ी कोलैबोरेट किया हमारे फार्माको विजिलेंस के इस प्रोग्राम में, और उनके साथ हम काफ़ी सारी एक्टिविटीज़ कर पाए. After that, I would like to thank all the faculty members who are here, especially to the Deputy Nursing Superintendent, sir, and all the nursing staff here. Apart from that, a big thanks goes to all the students who took interest in the event, जिन्होंने बढ़ चढ़कर हिस्सा लिया क्विज में भी और पोस्टर प्रेजेंटेशन में भी. साथ ही मैं अपने डिपार्टमेंट के सभी मेंबर्स का थैंक करना चाहूँगा जिन्होंने कोलैबोरेट किया. स्पेशली मैक्सिमम एफर्ट्स तो हमारे हेड के ही थे जिन्होंने इस प्रोग्राम को शेप किया और एक रियलिटी बनाया. आफ्टर दैट आई वुड लाइक टू थैंक आवर सपोर्टिंग स्टाफ, आवर क्लर्क विनोद जी एंड अदर स्टाफ, और स्टूडेंट्स जो हमारे साथ एज ए वॉलंटियर रहे. एंड प्लीज़ एक्सक्यूज मी इफ आई एम मिसिंग एनीथिंग एंड एनीवन. Thanks to all. Thank you.
Thank you so much, sir. Now we concluded the program here. Thanks to all of you for taking the time out from your busy schedules, and I also thank the students of batch 22 and 3. Thank you so much, everyone.
So the lunch for the faculty will be in this hall only, and for the students, the lunch will be in the common room for the students, right? Okay. Thank you.